Hi, I'm Dr. Mike McInnes. I'm one of the chief educators at Doctors in Training, and I want to welcome you to this solid anatomy lecture. This is the second of 4 introductory lectures. We'll be covering fascia, connective tissue, bones, and joints. Now I'll be back later for some clinical correlations and for the end of session quiz, but for now I'm going to turn it over to our primary lecturer, Dr. John Phelan.
The word fascia is rather vaguely defined, and while some use it synonymously with connective tissue, anatomists generally consider it to be a subset of connective tissue. Some connective tissue, like tendons of muscles, and the capsules of organs, are usually not referred to as fascia in anatomy. And some sheets of connective tissue are referred to as membranes rather than fascia. In this solid anatomy lecture, our discussion of connective tissue will define superficial fascia, deep fascia, subserous fascia, and membranes. The superficial fascia surrounds the entire body deep to the dermis and is composed of loosely arranged collagen and elastin. The superficial fascia is usually the site of most of the body's fat storage and thus often represents a tremendous energy reserve. Its thickness is dependent on the amount of subcutaneous fat an individual possesses. The superficial fascia also contains cutaneous nerves that end in the overlying skin, sweat glands, and blood and lymphatic vessels. Skin ligaments that connect the dermis to the deep fascia run through the superficial fascia. The looseness of the skin in any particular region of the body is dependent upon the length and density of these ligaments. They are short and thick on the palms of the hand and soles of the feet, where skin is tight and not particularly mobile, in contrast to the skin on the back or the dorsum of the hands and feet, which is easily pinched. Here, the skin ligaments are longer, fewer, and thinner. Deep fascia surrounds the limbs and every muscle in the body. The collagen composing the deep fascia is organized into densely packed parallel bundles that impart great tensile strength. This layer also has less elastin than the superficial fascia, resulting in greater rigidity. It has no fat. It has an associated vascular network in most places, although it used to be thought of as avascular, and it is highly innervated. The deep fascia is assigned different names in different regions. For instance, in the thigh, it's called the fascia lata, while in the leg, which is below the knee, it's called the crural fascia, even though these layers are continuous with each other. Extensions from the internal surface of the deep fascia form investing fascia around individual muscles, and form sheaths around neurovascular bundles. Extensions of the deep fascia also blend with the periosteum of bones and form intermuscular septae that compartmentalize the limbs. The inner surface of deep fascia in contact with muscle is covered with hyaluronic acid that allows muscles to glide freely against the deep fascia as the muscles contract and relax. The subserous fascia is found between muscles lining the walls of the body cavities and membranes that form sacs within the cavities. It is a loosely packed melange of collagen, elastin, and smooth muscle fibers. Examples are the endothoracic fascia between the pleural membrane and the muscles of the ribs, and the endopelvic fascia inferior to the peritoneum and dispersed amongst the pelvic organs. The endopelvic fascia condenses to form tough ligaments that anchor the uterus. You'll learn more about that topic in the solid anatomy lecture on the pelvic organs. Connective tissue also forms sheet-like membranes throughout the body. Some of these membranes have a layer of epithelial cells atop the connective tissue, such as mucous membranes and serous membranes. Mucous membranes line body cavities that open to the outside, like the oral and nasal cavities, and the digestive, reproductive, and respiratory tracts. Serous membranes are found in body cavities that do not open to the outside, namely the pleural cavities that house the lungs, the pericardial cavity for the heart, and the peritoneal cavity of the abdomen. Serous membranes line these cavities and cover the organs found within them. These membranes, named the pleura, the pericardium, and the peritoneum, will be discussed further in the solid anatomy lectures on the thorax and the abdomen. Membranes that consist entirely of connective tissue include the meninges, which cover the brain and spinal cord, the periosteum, which covers the bones, perichondrium, which covers cartilage, fibrous pericardium, which covers the serous pericardium around the heart, and the synovium. The synovium lines the inside of joints and secretes synovial fluid that reduces friction between the articular surfaces of the bones involved in the joint. Synovium also forms bursae, which are fluid-filled sacs outside the joints that reduce friction between the body and hard surfaces the body may come in contact with, and synovial sheaths that form low-friction tunnels for some tendons to pass through.
Welcome back. Since we're discussing the fascia, let's talk about some clinically important conditions that involve the deep fascia. So Dr. Phelan mentioned the fascia can be superficial, deep, subserous, or membranous. So here we're talking about the deep fascia. So the first condition is an infection of the fascia called a necrotizing fasciitis. And the other condition we'll discuss is increased pressure inside the fascial compartments, which is called compartment syndrome. But let's start with necrotizing fasciitis. This occurs when the deep fascia becomes infected, usually after trauma or surgery when the skin's been opened up. However, the fascia can become infected without an insult to the skin, for instance, from hematogenous spread of infection from some other site. Risk factors for necrotizing fasciitis include diabetes, immunocompromised patients, and patients with peripheral vascular disease, but it can happen to healthy individuals as well. Most cases are in the lower extremities, and the bacteria most commonly responsible is Streptococcus pyogenes, also known as group A strep. So I'd be aware of that association. There are other bacteria, but Strep pyogenes is the most famous one. Now, once the fascia becomes infected, the infection can spread along the fascial planes and get into the surrounding subcutaneous fat and destroying the tissue. One of the difficulties with making the diagnosis early on is that there may be no skin manifestations at all. There's nothing visible at first, so it can be hard to identify the infection. After a while, the overlying skin can become red. You can have areas of bluish gray. You might see what we call bullae, or large blisters. And even further along in the progression, you can see full-on cutaneous infection. Now, to make a definitive diagnosis, you need to do surgical exploration and culture the infected tissue. Then to treat, you have to debride the entire area, cut away all the necrotic infected fascia, which we call a fasciectomy. And you also have to debride the surrounding soft tissue. Now, it can be quite a gruesome surgery because there can be a lot of surrounding tissue involved. Sometimes you have to do grafting or reconstructive procedures, and in bad cases, amputation may be required. The second condition I want to discuss is called compartment syndrome, which can occur again in the lower extremity, but also in the upper extremity. This is when the pressure inside one fascial compartment compromises blood flow and tissue function. Take a look at these different fascial compartments of the leg. You have the deep fascia and the intermuscular septa dividing the thigh into posterior, anterior, and medial compartments. These are actually distinct, separate compartments. Now, if there's a trauma like a crush injury, or if there's a femur fracture, it can increase the pressure within the compartment. As the pressure in the affected compartment rises, it compresses the nerves, and the patients are going to have a lot of pain out of proportion to their injury, and then paresthesias and numbness over the affected fascial compartment. They can have impaired blood flow, and eventually necrosis of the muscles and the nerves in the compartment. A fasciotomy is the treatment here. Now, this is a little different than the fasciectomy we described with necrotizing fasciitis. A fasciotomy is where you make an incision in the fascia and you open up that compartment to release the pressure, but you're not actually removing the fascia like you would with a fasciectomy for necrotizing fasciitis. Now, you can see how with compartment syndrome, it's important to know the various fascial compartments, both for diagnosis and for surgical treatment. Now, we're going to cover these fascial compartments in detail in the lower extremity lectures. But for now, let's pick back up with the bones.
The bones may be considered a specialized type of connective tissue as well. In the fetus, the skeleton is mostly made up of cartilage, which is a flexible tissue consisting largely of collagen produced by cells called chondroblasts. Osteoblasts and osteoclasts replace the chondroblasts as the fetus nears birth. The osteoblasts use calcium and phosphate from the blood to create hydroxyapatite crystals, resulting in ossification of the skeleton, while the osteoclasts are involved in remodeling the bones as they develop. A typical bone consists of a dense shell of cortical or compact bone surrounding trabecular or spongy bone that has numerous spaces. The space found in the center of some bones is the medullary cavity. Marrow, which is the source of red and white blood cells, and platelets, is often found in the spaces amongst the spongy bone and in the medullary cavity. The marrow and deep parts of the bones are supplied by nutrient arteries that branch from arteries running near the bones. They enter the bones via openings called nutrient foramina. The ends of bones are usually supplied by branches of the arteries forming anastomotic networks around joints. However, most of the compact bone is supplied by small arteries running in the periosteum, the connective tissue membrane that covers every surface of the bone except for the articular surface, which is covered by cartilage. There are few nerve endings on the bone itself, but the periosteum is highly innervated, and tears in the periosteum due to breaks in the bone or other insults are sensed through periosteal pain fibers. The 5 main classifications of bones are long bones, like the humerus, which have a tubular shape; short bones, specifically those in the wrist and the ankle; flat bones, which are usually protective, like the bones making up the neurocranium, which is the portion of the skull that encases the brain; irregular bones, which have varying shapes, like those making up the viscerocranium, which is the portion of the skull making up the face; and sesamoid bones, like the patella, which develop in tendons at points where the tendons cross the bones to protect the tendons from wear and to increase the mechanical advantage of muscles acting on the joints. The function of bone is to provide support for the body and protection for the soft, vital organs, to store calcium and other minerals, and to enable movement by acting as levers and points of attachment for muscles.
Since we're talking about bones, let's talk about osteoporosis, which is a very important disease in the U.S. as our population is getting older and older. First of all, what is osteoporosis? That's the first question in your study guide for this clinical correlation. Osteoporosis is a disorder of the skeleton characterized by decreased bone mass, which puts the patient at risk for fractures. Sometimes people tend to think of bones as these dead, static organs that don't really change. But this isn't true. They're constantly turning over old bone and making new bone. Now in the lecture, Dr. Phelan mentioned osteoblasts and osteoclasts. Osteoblasts use calcium and phosphate from the blood for skeletal repairs, or in other words, they make new bone. Osteoclasts are involved in remodeling the bone, or in other words, they absorb or resorb old bone. So osteoclasts are the demolition crew, and then osteoblasts are the construction crew. Now normally there's a balance between osteoblastic activity and osteoclastic activity, a balance between the demo and the construction. And that's going to allow bones to remain adequately dense. But with osteoporosis, there's a disruption of this process. The underlying pathology of osteoporosis is either too much osteoclast activity or too little osteoblast activity. And the result is decreased bone density. Who's at risk for osteoporosis? This is important because you need to know who to look out for. Osteoporosis is generally silent until there's a fracture of the wrist or the hip or maybe a vertebral body, and then it's too late. So you need to know these risk factors. The risk factors are increasing age, being a postmenopausal woman because estrogen is somewhat protective, being white or Asian puts you at a higher risk than being black, smoking increases your risk, poor calcium and vitamin D intake, glucocorticoid use, Lack of weight-bearing exercise is a risk factor. Being thin also increases your risk. This is one of the few health advantages that overweight and obese people have over the thin. When you're heavy, you're definitely subjecting your bones to more weight-bearing exercise just walking around. So being thin increases your risk of osteoporosis. How do we diagnose osteoporosis? Well, this is done with a test called a DEXA bone density scan at the lumbar spine or at the femur. Now, DEXA stands for dual energy X-ray absorptiometry. I won't get into how it works because we're already getting pretty far away from anatomy. Then to treat osteoporosis, there are lots of different medications, but the mainstay of treatment is a class of drugs called the bisphosphonates. You may have heard the brand name Fosamax, which is a bisphosphonate called alendronate. That's the generic name, alendronate. So all the bisphosphonates, like alendronate, work by inhibiting osteoclasts. So you're inhibiting the demo crew, which is going to favor bone construction overall. So treatment is a little beyond what we want to discuss here, but you should kind of tuck that away for later. Osteoporosis, bisphosphonates. So that's it for now. Let's get back to Dr. Phelan and talk about joints.
Motion of the skeleton occurs at joints, which are places where bones come into contact or articulate with each other. The three main categories of joints are fibrous, cartilaginous, and synovial. Fibrous joints are named for the fibrous connective tissue that holds them together. The three types of fibrous joints are sutures, syndesmoses, and gomphoses. Suture joints are only found among the bones of the skull. They lose their mobility after birth and usually eventually fuse. The articular surfaces of the bones of the suture joints may be serrated and interlocking, wedge-shaped and overlapping, or simply smooth and abutting each other. Syndesmoses often allow some motion. The fibrous connective tissue that binds them includes interosseous membranes in some instances. These include the joints of the bones of the forearm. Gomphoses are the joints between teeth and their sockets. Fibrocartilage, which is made up of collagen and other connective tissue components, binds the bones involved in cartilaginous joints together. In primary cartilaginous joints, or synchondroses, the bones are united by a plate of hyaline cartilage and usually ossify with age, as in the epiphyseal growth plates at the ends of the long bones. Secondary cartilaginous joints, or symphyses, usually feature a cartilaginous disc between the bones, such as the intervertebral joints, or the pubic symphysis. Synovial joints, such as the elbow joint, have a fibrous capsule derived from deep fascia that usually attaches firmly to the ends of the bones involved in the joint by blending with their periosteum proximal to their articular surfaces. Adjacent ligaments often blend in with the capsule to thicken and strengthen it. On the internal surface of the fibrous capsule is a synovial lining that secretes a lubricating synovial fluid that reduces friction between the articular surfaces of the bones forming the joint. The synovial lining does not cover the articular surfaces of the bones, which are instead covered by hyaline cartilage, which is thought to be nourished by the synovial fluid. There are 6 types of synovial joints. The bones forming plane joints, such as the sternoclavicular joint, have relatively flat articular surfaces that allow them to glide across each other. Hinge joints, like the elbow, allow only flexion and extension. To envision a saddle joint, consider mirror images of a saddle and twist one saddle 90 degrees so its convex surfaces line up with the other saddle's concave surfaces, allowing the two saddles to fit together. This joint allows motion in 2 axes, such as flexion and extension, and abduction and adduction, as well as the sum of these actions, which, as we mentioned earlier, is circumduction. The first carpometacarpal joint, where the thumb attaches to the hand, is the standard example of a saddle joint. The same actions are possible across a condyloid joint, in which one articular surface is convex and the other is concave. The first knuckle joints, or metacarpophalangeal joints, are condyloid joints. Ball and socket joints, like the hip joint, feature a very convex-shaped head of one bone fitting into a very concave, socket-shaped receptacle on the other. These are very mobile, multi-axial joints. In a pivot joint, there is a central bony axis on one bone around which another rounded bone rotates. The best example is the atlanto-occipital joint, where the posterior arch of the atlas, or first cervical vertebra, articulates with and rotates about the vertically oriented odontoid process of the axis, or second cervical vertebra. Synovial joints receive a substantial vascular and nerve supply. Arteries often form anastomoses around joints, that is, connections among arteries without an intervening capillary bed. This ensures adequate blood supply across the joint if changing the angle of the joint compresses one or more of the arteries crossing it. Hilton's law states that nerves innervating the muscles acting on a joint give sensory branches to that joint, as well as to the skin over the area of attachment of these muscles. These sensory nerves are involved in transmission of pain from the joint capsule and any associated ligaments, and, to a lesser extent, from the synovium. They are also involved in proprioception, a sensation that allows awareness of the position that the joints are in.
Let's talk just a second about a disease of the joints called degenerative joint disease, or DJD, or another name is osteoarthritis. Now, arthritis just means inflammation of the joints. Itis means inflammation, so if you have inflammation of the sinuses, that's sinusitis. If you have inflammation of the appendix, that's appendicitis. If you have inflammation of the joints, that's arthritis. Now, there are lots of different specific types of arthritis. We're going to talk about osteoarthritis here, which is the most common type of arthritis out there. Unlike autoimmune arthritis, like rheumatoid arthritis, where the patient's own immune system attacks the joints and tears them up, with osteoarthritis, it's caused by what we call wear and tear on the joints. Now, Dr. Phelan mentioned how the ends of bones are covered with an articular cartilage, and then synovial fluid reduces the friction between the articular surfaces of the bones. Osteoarthritis occurs when there's destruction and erosion of the bone's articular surface. The disease occurs primarily in the hips, the knees, the vertebral column, and the hands, but it can also occur elsewhere. Osteoarthritis comes on very gradually, and depending on the severity and the progression of the disease, you can treat it with Tylenol or non-steroidal anti-inflammatory medications. You can treat it with steroid injections into the joint space, and also joint replacement. Now, we've mentioned briefly rheumatoid arthritis and also osteoarthritis, but there's another type of arthritis called septic arthritis. Remember from the lecture that synovial joints receive a substantial vascular supply, and because of this, bacteria can infect the joint from the blood. So we use the term septic arthritis to refer to a bacterial infection of the synovial fluid of a joint, most commonly through hematogenous spread. However, it can be from direct insertion of bacteria from surgery or from trauma. Now, in septic arthritis, you have a very painful joint which comes on very suddenly and very quickly, not like osteoarthritis. And there's normally a fever with septic arthritis. If you suspect septic arthritis, you're going to need to insert a needle into the joint and pull out some synovial fluid and see what's causing the infection. Staph aureus, streptococcus, and Neisseria gonorrhea are common bacteria that cause septic arthritis. A common clinical situation is a young person with a sexually transmitted infection who develops an inflamed knee, which would suggest septic arthritis caused by Neisseria gonorrhea. So that completes our discussion on the connective tissue and the bones and the joints. Now I want you to pause the video and answer the end-of-session quiz questions, then we'll go through those answers together. Let's get going. First question, what's the function of bursae? Well, these reduce friction between the body and hard surfaces that the body may come in contact with. Next, what are the 5 main classifications of bones? So you have long bones, short bones, flat bones, irregular bones, and sesamoid bones. Next, what are the three main categories of joints? Well, there are fibrous joints, cartilaginous joints, and synovial joints. Next, what are the three types of fibrous joints? So you have sutures, syndesmoses, and gomphoses. Next, what type of joint features a cartilaginous disc between the bones, such as the intervertebral joints? This is a symphysis. Okay, we're almost done. We've provided some images for you to label and also some different joints where we want you to classify the type of joint. So label the images as they come on screen and classify the types of joints provided, and then we'll be finished. Thanks.